Hi, my name is Sandra Arevalo, and I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital. Today, as in every other community chat, we have a very special person. And today, Lauren Fedrighini from Burke Rehab is going to be talking to us about rehab, what it is, when it's needed. And, I know that a lot of people, especially, when you have elderly under your care, you might be thinking about rehab or maybe after a surgery, and we don't have a lot of information on how all of that works. So today is the day that we're going to learn about rehab, how that works, how we bring a person into rehab, who is it for, when is it needed. And that's why Lauren is here. So welcome, Lauren. It's such a pleasure to have you. And it's been great working with you the last couple of weeks, trying to put this presentation together.
Yes, thank you so much. I really appreciate getting the opportunity to give this presentation and hopefully share some information with everyone.
And as our participants can see, she has already shared the presentation on the screen. So, Lauren, you can feel free to start, but tell us a little bit about you first. Like, what do you do at Burke?
Okay, so right now at Burke, I've worked at Burke for 21 years. I worked as an occupational therapy assistant, so I was throughout all of the different units there. I've worked in a stroke unit, I've worked in the cardiopulmonary unit, the orthopedic unit, all of the different units. I did that for 20 years. I've just transitioned into a role where I am a care transition coordinator. So now I'm screening patients for admission into Burke. So I go through the medical record and I make a recommendation to our doctor on whether or not this patient may or may not be appropriate for admission to Burke. And I've also been working, I'm also the liaison for Nyack. So I meet the patient, if you're a patient at Nyack, I would meet you there. I would, answer any questions that you might have about Burke, explain a little bit about Burke, and I work with the case managers and the nurses and rehab in assisting patients with admission to Burke.
Mm-hmm. Thank you so much.
That's my role now.
Yeah, thank you for your introduction. And then just a reminder to all of our attendees that are joining now, this meeting is being recorded, but we care about your privacy. So if you want to make any questions or any comments, or you want to discuss a case that you might be thinking of, please use the Q&A in the chat. I'll be your voice. I'll be voicing all of your questions, and we're going to get all the answers that you are looking for from Lauren today. So go ahead, Lauren.
Okay, thank you. So I already covered a little bit about me, so I'll move on to the next slide. So just a little bit about Burke. Burke is a nationally recognized and accredited not-for-profit healthcare organization providing leading physical rehab treatment, graduate medical education and research. The mission is to provide the highest quality medical care and rehab services to ensure that each patient achieves the maximum functional recovery from illness, injury, or disability. Our vision is to lead the field as the most effective and compassionate provider by practicing innovative treatment, pioneering clinical research, and inspiring education. So we're the only hospital in Westchester solely dedicated to adult and adolescent rehab. We have 150 beds. We're located in White Plains with 12 satellite locations for outpatient located throughout Westchester County, Hudson Valley, and the Bronx, with additional sites planned. We're actually going to be opening up a site in Rockland County, so that's very exciting. So that way, so a patient from Nyack that might have come to Burke can then go, when they're home, can continue to follow up with outpatient in Rockland County and have it be a Burke facility. So that'll be really exciting. We've been named a top rehab hospital in U.S. News and World Report, and we have the lowest hospital readmission rates in the country. So what exactly does that mean? So lowest hospital readmission rates means that we have the least amount of patients needing to be readmitted into a hospital after discharge, after they've been discharged from us. So that's really good news, because after you've been through such a an ordeal and a rough experience, you've been in the hospital, then you come to us and you want to go home, the last thing you want to do is wind up coming back into another hospital. So that's a really, really a really good number. Okay, so what exactly is rehab? Rehab is care that can help you get back or keep or improve abilities that you need for daily life. These abilities may be physical, mental, and or cognitive. Cognitive means thinking and or learning. You may have lost them because of a disease or injury or as a side effect from a medical treatment. The main goal of short-term rehab is to help patients make their best possible recovery as quickly as possible. This is accomplished through individualized and comprehensive treatment and therapy from a multidisciplinary team of rehab professionals. So rehab is really how you're going to get back. So you had a stroke and now you're not able to dress yourself. You're not able to walk. So you need rehab in that situation so that you can gain that independence back. So sometimes if you have a stay in the hospital, you're not able, you get weak, or the different reasons what landed you in the hospital make it that you're no longer independent and able to take care of yourself. So at that point, it's very important to come for rehab so that you can go home and resume being independent at home. And sometimes you need sometimes you're not in a hospital and you require outpatient rehab because either you might be independent, but things are painful, or you notice that you're walking and you're not, your balance has gotten a little bit degraded, so it has gone down. So that's another reason why you might go for some like outpatient therapy type things. And what I hope that you gain from my presentation today is that I want you to have this information before you need it, right? I want you, because when you get into a hospital and things are stressful, being in the hospital is, of course, a stressful time for most people. It's one of the most stressful things we go through. You want to be armed with that information because at that point, it's hard to take in, it's hard for you and it's hard for your family to take in all of that new information. So it's good to come prepared and have it like in your back pocket so and you've thought about it a little bit. Hopefully this gets you to think a little bit about what you might do if you find yourself in this situation. So the different types of rehabilitation are acute rehabilitation, subacute rehabilitation, outpatient therapy, and home care therapy. And my presentation is going to really be going through these different types of therapy. Okay, so acute therapy is when you come, is therapy that is 3 hours of therapy per day. That's a big thing because at acute therapy, we offer more therapy than other places. It's a bout of intense therapy so that you can get home and independent quicker. Because being that you have 3 hours a day, it means that you don't need to stay with us as long as you might stay at another facility. So some of the acute rehab admission requirements are that you have to be sufficiently medically stable. Your labs need to look good. Your vital signs need to look good. You need to have things like, blood pressure that's, being managed, be not have a fever for 24 hours without medication, and things like that. And you have a need for intense interdisciplinary approach to rehab. So acute rehab means that you need more than one discipline. So discipline means OT, PT, and speech. So that you need occupational therapy and physical therapy. And you may need speech as well, but you have to at least need two. You have to at least have a need for physical therapy and occupational therapy. Physical therapy, just to explain the difference, physical therapy will work more with you on balance and, are you able to do the stairs at home, how you're walking, the quality of how you're walking. So, maybe you're walking, but it could be better. What ambulatory device? An ambulatory device is a rolling walker or a cane. So which one of those devices will you need to be safely independent at home? Occupational therapy deals with all of the things that you need to do every day. So that might be getting dressed, getting in and out of the bathroom, can you take a shower? And once those basic needs are met, then we like to move on to the more higher level ADLs. Well, can you make yourself breakfast? Can you make yourself lunch? And all of those kind of things. And can you get in and out of a car? So those are the things that OT would focus on in rehab. So in order to be admitted into acute rehab, you need to meet those two disciplines. There may be a need, of course, if someone has had a stroke or any other brain injury or any kind of issue swallowing, that you also may need speech therapy as well. So that's what I mean when I say an intensive interdisciplinary approach to rehab. That you have the ability to progress and demonstrate measurable gains as a result of skilled therapy. So that if you require, let's say, that someone does half the work for you, let's say to get in and out of bed, that we think in the time that you can come to acute therapy, that we could make you independent in that, and that would be considered a measurable goal. That you're able to tolerate the intensive therapy. So again, you need to be able to tolerate 3 hours of therapy per day. You need to have the daily need for daily physician management, because we have, unlike subacute, we have a doctor there 24 hours a day. And that you have a need for 24-hour rehab nursing care, and that you're able and willing, like you want to participate in a 3-hour program. You're agreeing to it. You're saying, hey, I'm ready. I want to really get the most out of my rehab, and I'm willing to participate in the 3 hours of therapy a day. Okay. I was just checking to see if there are any questions. So some of the rehab diagnoses, stroke, brain injury, spinal cord injury, any kind of neurological disorder such as multiple sclerosis or Guillain-Barré. If you fracture your hip, if you have a lower extremity joint replacement, typically now, as insurance regulations change, it's harder to come into an acute rehab. If you are a single joint replacement, it really only happens if you have both knees done or both hips done, you're obese, greater than 50% BMI, or you're older than 85 years. I've also seen it happen if you have a lot of comorbidities. Sometimes if you are a single joint replacement, but you also have Parkinson's disease, or you're a single joint replacement and you have MS, we may be able to get you in and your insurance might pay for it, but it is a little bit more difficult than it used to be for sure. If you've had an amputation, if you have an active osteoarthritis in 3 or more weight-bearing joints, rheumatoid arthritis, active involving multiple joints, systemic vasculitis with joint inflammation after failing outpatient treatment, and any kind of congenital deformity. I also just wanted to point out, because this list didn't include, if you have COPD and you're in the hospital for an exacerbation, or CHF and you're also in the hospital for an exacerbation, then it can be very important for you, and that's certainly a diagnosis that's covered for acute rehab. Getting that pulmonary rehab or that cardiac rehab is certainly very important, and there's a lot of different things that we teach when it comes to that. Okay, so once you're in the hospital, let's say this is if you're coming from, if you're a patient in let's say you're a patient in Nyack Hospital, or if you have a family member in Nyack Hospital, because again, in order to come into acute rehab, you need to be in an acute care hospital. So if you're a patient at Nyack, you're a patient at Good Sam or at any other hospital, and they decide that you can't go home by yourself, it wouldn't be safe, then they're going to recommend rehab. And once they do, we're one of the options. So who decides where you need to go to rehab? So
Lauren,
when you're in,
let's interrupt, but we have a question about this.
Sure.
And here it is: Medicare does not cover knee replacement rehab unless you are in the hospital for 3 nights. Now,
Right.
You are discharged from the hospital after 1 night and sometimes the same day. Why the disconnect?
So again, for single joint replacements, typically they're not covered anymore for acute rehab. They're only covered when there's the comorbidities I mentioned. So you're being severely obese, you're being older than 85, or you have a comorbidity. And in those instances, it is most likely that you'll be spending more time in the hospital. Now, those 3 nights that you're speaking of don't apply to acute rehab. That's a subacute requirement. So we don't require the 3 midnights. And when you're coming to acute, there isn't that same requirement as required for subacute through Medicare.
Thank you, Lauren.
But also, if you have those comorbidities, the chances are that you're going to be staying in the hospital longer anyway. Okay, so who decides where you need to go to rehab? So your PT and OT in the acute care hospital will make a recommendation about the level of rehab that is most appropriate for you. So if you're in the hospital, you should be being seen by physical therapy. Sometimes hospitals don't have very many OTs, or they might not have OT at all, quite frankly. So in that instance, you might not be seen by an OT, but we're able to take that information from nursing. So we can have nursing tell us, hey, listen, this patient requires this much assistance with dressing or bathing or getting in and out of bed, or all the things that are typically OT needs. This recommendation is relayed to your care team, either in rounds or by other means of communication. So in the rounds, your doctor's there, your case manager's there, usually a therapist is there, and they'll come together and they'll discuss discharge. They'll discuss medically, of course, how you're doing, because that's firstly most important. And then they're going to discuss discharge planning. And that, you might be shocked when you're in the hospital how soon and sometimes how fast they're talking about rehab, but really they're thinking about it almost as soon as you get there. Like, what is the plan going to be? So you have a case manager working on that with you. So if you have, if they determine that it wouldn't be safe, so some of the options are acute rehab and subacute rehab if they decide that it's not safe for you to go home, or home care therapy and outpatient therapy. So right now we're talking about acute, and then I'll get to the other different kinds. So some of the obstacles when you're trying to get into really whatever rehab is insurance denying, physician's inability to appeal the decision of the denial, patient's ability to tolerate intense rehab, 3 hours, and discharge disposition, ability of family member to take patient home and care for them. So just to dive into that a little bit more, acute rehab is the most expensive form of rehab. So insurance, of course, makes what needs to, for your rehab team and for your case manager and the doctor when there's an appeal, to make the determination and to really specify why you need this level of care over subacute or over one of the other levels of care. We need to say why you'd benefit from the 3 hours and why you'd benefit from 24-hour nursing and why you would benefit from having the doctor having the doctor there 24/7. And so we really, as a screener at Burke, when I do my screen, it needs to make a really good case for that. And so that's typically what I do. And sometimes I make that recommendation and then our doctor signs off on our referral. And then if that gets denied, then the next step, of course, is the physician at the referring hospital will make an appeal. Sometimes that appeal goes through and sometimes it doesn't. That you might hear this lingo going around, but it's called a peer-to-peer. And so the doctor from the hospital calls the doctor at the insurance company and they try to work out, and the doctor really tries to make a case for it. And sometimes that also gets denied, and then there's another level of appeal. But those are just some of the barriers. And really the patient, like when I'm looking, really needs to be well in the medical record that the patient can tolerate the intense rehabilitation. So if you're your family member, you're in the hospital and you're getting the rehab coming and you're having therapy in the hospital, but you're tired after 10 minutes, or you've been telling therapy, I can't see you, I'm too tired. Those are really reasons why it might be difficult to accept a patient, because we really need to make sure that they can really tolerate it. And physical therapy really is good at, giving us that recommendation. Physical therapy, occupational therapy from the referring hospital can really be good at making that recommendation. So once you make that decision, what happens is that you provide your choices to the hospital case manager of the places that you want to go. They will send the referral to your selected places. The referral is reviewed and then a decision is made. In some cases, insurance authorization will need to be obtained. If you're someone that just has Medicare, then you typically don't need authorization. It's really more the private insurances that all need authorization. And this can sometimes take a day or two. So it's important to get, so you may be thinking, oh my goodness, why, I'm going to be in the hospital a few more days. Why are they trying to send me out of here? But it's because we want things to fall into place at the right time. There may be multiple bed offers. After you pick where you want to go from the accepted facilities and you're medically ready for discharge, transportation to the facility is arranged by your case manager. One important thing that I just want to note is that it's very important that you go to the level of rehab that's recommended for you. A lot of times patients pick a place because it's closer. They pick a place because it's convenient for families to come and all those different things. And while I definitely see the benefit, of course, of family being able to come visit, it certainly does well for your mental status and all of that. It makes you feel comfortable and all of those things. It really is best for you that you choose the level of therapy that's recommended. So if you're being offered acute and you're being told that acute is the best option for you, it really is worth it to make even if you have a little less company, even if you have a little, it's a little bit further for your children or friends, whoever, to come visit you, you really should do it for yourself and make that decision because it really is important. And don't forget that we're intense therapy that gets you better quicker, so you'll be home faster. And I also like to stress, the time that you're really in a situation like this, where your family is going to be really, really necessary, is not while you're in a rehab. It's actually after you've gone home. You might need somebody to do grocery shopping for you, to help you with bathing, to help you with cleaning, just to help you doing things around the house, and certainly at first in that transition. So it can be difficult if your family member has kind of exhausted all of that before you've even gotten to that point. So it's just something to keep in mind when you're planning, that really kind of take the time for yourself and really pick the level of care that's recommended. And also vice versa, if subacute is being recommended, really certainly advocate for yourself and make sure you get a good reason why. And maybe it's because they think you can't tolerate 3 hours, or they don't think you have measurable goals enough. Whatever the reason might be, you also want to get that information so you're fully informed yourself. Discharge planning from acute rehab therapy. Discharge planning, once you get to us, happens from day one. The decision when you go home is a multidisciplinary approach. So in that meeting, when you're in an acute rehab, it's your MD, nurse, OT, PT, and social work will meet in rounds and pick a discharge date. The average length of stay is anywhere from 10 to 14 days. Give or take, of course, you might do really well and go home quicker, or you might need a little bit more time. So it's not set in stone. That's just a typical average. The acute rehab is most often the first phase of rehab, right? So there's going to be, patients can be discharged from acute to the following: home with either outpatient or home care services. That's our number one goal. So when you come to us, our goal is to get you home. Some patients will need to be discharged to subacute. So that happens for one big reason is, so you come to us and you're doing really, really well. You're making your goals, you're doing really well, but sometimes the progress plateaus. So it flattens out. And it's not to say that you're not going to get better, but you need more time. So you need more time than you can stay in an acute rehab, right? Because going back to when I said that acute rehab is more expensive, you're only able to stay in acute rehab for the 10 to 14 days, or maybe, a little bit more give and take. But if it looks like it's going to require more time than is feasible, then they may recommend that you're being discharged to a subacute. And a subacute, is still able to offer the daily therapy, and it's able to give the assistance that you'll need. Because either, sometimes the discharge plan happens to be that you'll need discharge with 24 hours of care, or you can go to a subacute. So of course, subacute is able to give you that care that you'll need and that assistance and the daily therapy, and you won't have to pay for a 24-hour home health aide. So that's really, the benefit of that. So who pays for rehab? Mostly Medicare and Medicaid pay for rehab, and also private insurances pay for rehab. Most insurances require, except for, like I said, Medicare, and if you have straight Medicare or straight Medicaid, which means that you just have Medicare and Medicaid, you're not, it's not like an Aetna Medicaid or a Blue Cross Blue Shield Medicare, or, however that goes, it's just straight from the government, then it doesn't require authorization. All of the other private insurances will require authorization before a patient can be admitted, and that sometimes takes a day or two to get. So subacute rehabilitation. Subacute is therapy that happens in the unit of a skilled nursing facility. A skilled nursing facility is typically what most people think of when they think of a nursing home. Patients get a maximum of 1 to 2 hours per day of therapy. They offer all 3 disciplines to include PT, OT, and speech. Therapy is less intense than acute rehabilitation, but certainly more intense than if a patient is discharged to home. Patients can stay at this level of rehab for a longer stay versus acute rehab, which is a shorter stay. So just as an example, Medicare pays for 100 days of subacute a year. Out of those days, 20 days are without a copay, and then after that, there's a copay each day for the stay, but they will pay out. It used to be $100. Don't quote me on that. I think it's about around there. But that's what you would be charged a day after from 20 to 100 days. You would be charged a copay. So again, this is a good option when patients would not tolerate acute therapy, and it's also a good option when being discharged from acute and you need physical assistance and you still benefit from daily therapy, like I said before. And this follows the same, how you're referred to subacute, of course, follows the same example as I was giving you before. As your team will meet, they'll make the determination that you're going to go to subacute. They'll provide you, your case manager will provide you with choices. And you can look it up on Medicare's website, and you can do your due diligence and research, or have your family do it, so that you know the best place to go. And then you'll give your choices, and they'll apply to subacutes just like they would have applied to acute. So just a little comparison and contrast between acute rehab and subacute rehab is that you can just look through it and see that there's daily physician rounds and an on-site medical team, where in subacute physician visits are much less frequent. So sometimes they have a doctor that comes in the morning and then leaves. Where we have a doctor that's there 24 hours a day. The acute rehab is 3 hours a day or 15 hours a week of therapy. In subacute, there is no requirement really. It could be as little as 1 hour to a maximum of 2 hours. And you can see that the hospital readmission rate is a bit higher, so it's 6.7 in acute as compared to 7.8. A successful return home to the community is higher with acute than it is with subacute. A change in the patient's ability to move is 32% versus 16%. And that really it speaks to our ability to have that intense therapy, and that 3 hours of therapy a day is really, really crucial as compared to an hour. And finally, the percentage of patients who are at or above an expected ability to care for themselves at discharge is 62% versus 46%. By and large, when most patients are discharged from a subacute, they really require home care services. They're not really able to get themselves to outpatient, where we really have a fairly high number of patients that are able to go to outpatient therapy after they leave us. The one thing I just wanted to go back to is just to say that Burke Rehabilitation Hospital is only acute therapy. So we only offer acute. There are other rehab hospitals out there that offer both acute and subacute. It's very important that when you're comparing us, let's say you're a patient in the hospital and you've got accepted to Burke and you've got accepted into another facility. When you get accepted into that other facility, it's very important that you know what part of the facility they've accepted you into. Have they accepted you into their acute, or they have accepted you into their subacute services? Because now that I'm hopefully giving you this information, you'll know the difference and know to advocate for yourself. Because if Burke's offering you acute and that other facility is only offering you subacute, then you'd want to pick the acute rehab, because of course, again, it's more intense, it's better for you. So if it's being offered, it's really the way you want to go. So you just want to make sure that when you're doing your comparison, that you're comparing apples to apples and not apples and oranges. So another option is outpatient therapy. So it might be, outpatient happens. Of course, outpatient happens when we're just out. Any of us can go to outpatient at any time. If you're having, outpatient can help with pain. It can improve your balance. It can help with weakness. It can help with all different sorts of diagnoses that you might get referred to outpatient, either physical therapy or occupational therapy or speech therapy. So, and Burke has outpatient. There's a lot of outpatient places in Rockland County. And you might just be referred by your doctor to go to outpatient therapy, and that's wonderful too. So in this, and I've been really kind of stressing all of the different, if you're a patient in a hospital, but of course outpatient is really for everyone. Outpatient therapy can be carried out in hospitals, private practice PT clinics, doctors' offices, rehab facilities to help treat a variety of different muscle, joint, and movement disorders. Outpatient therapy almost always entails performing therapeutic exercises that help strengthen weak muscles and stretch muscles that are too tight to restore balance, improve posture, functional strength, and range of motion, and decrease pain. PT, OT, and speech are all available as outpatient. And again, we have 12 outpatient locations, and there's going to be one opening up in Rockland and West Nyack, which is very exciting. So home care therapy. So home care therapy is provided when a patient is homebound. Home care therapy is available. This is where a therapist, PT, OT, and/or speech come to the house to provide therapy. This service should really only be used when a patient is unable to leave their home, as there is more of a benefit to attend outpatient therapy. So if it's unsafe to leave the home, if you're at a high risk of falling and leaving the house means that you would most certainly fall, or if you can't do stairs, or if by the time you got to outpatient, you would be too tired to actually do the therapy, which would happen, then home care therapy is a really good option for you. This service also includes a home health aide and a home health aide a few days a week and an RN visit. And there are multiple home care agencies that provide this service. And if you're not getting it referred from as a patient in the hospital, then your primary care doctor should be able to recommend home care therapy. The benefits though of home care versus outpatient is that there's more space in outpatient. So the therapist that comes to your house is kind of limited to your space, right? They're not able to walk long distances, and there's no machines. And also the benefit is that it gets you in and out of the house. But the benefit of home care is that if you are having difficulties getting in and out of the house, the therapist can then come in and work with you on those specific reasons why you're having such a hard time. So that's definitely a benefit of it. So just the conclusion, the biggest takeaway that I want you guys to leave with is that when you're given the choice of acute or subacute, it is always best to go with acute, as it leads to better outcomes if you're the patient or for the patient. Subacute is a great option when acute rehab is not appropriate or when the patient isn't able to return home after acute rehab is provided. If a patient is able to leave home, then going to outpatient therapy is always a better choice after a rehab or whenever that comes up. And then I just have my contact information. And of course, I would love to open it up. If anybody has any questions they want to ask me, that would be great.
Thank you so much, Lauren. This was really helpful because, for example, by myself, I didn't know that there were different kinds of, I knew about occupational therapy and physical therapy, speech therapy, but I didn't know there were also different levels that you can get when you get out of the hospital. Now, while our attendees ask any questions, please use the chat, the Q&A, send us comments, questions, but I do have a question for you. Home care, you were talking about home care. How does it get decided when people need care at home? Because you were saying, there are spacing issues and some other issues when you're at home. So how do you decide if it's a good fit or not?
So typically when we're meeting, if you're a patient, let's say you're a patient at Burke and I'm a therapist and I'm trying to determine whether you're going to go home with outpatient or home care, it's whether or not you'd be safe leaving the house. So we work with you on those, it's called community skills. So we work with you very closely on those community skills. Can you go up and down curbs? Can you do stairs? Can you manage getting in and out of the car? Can you, if by the time that you got to therapy, you would be so tired to do the therapy, then those are all things to think about on whether or not a patient can do outpatient therapy. Home care is really good when there's, home care is good certainly when there's certain issues that need to be addressed at home. If the stairs are at home are going to be difficult and you're not able to do them, then certainly home care is really a great option. But outpatient, what I mean by space is the outpatient are usually in large gyms. There's more space to walk around. So there's more of a benefit to it. The PT can fine tune your gait a little bit more. They have a little bit more time with you. Outpatient care, you get a 30-minute session typically, but they're able to hey, why don't you end on a machine after your 30 minutes with me is over? Or come early next time and start at a machine. So they have more time with you. Whereas if someone is coming to your house, to be honest, they're looking to get in and they're looking to get out because they have to get to their next patient. They have to do their documentation. So there's, there's fallbacks. There's advantages and disadvantages, of course, to everything. And so those are just some of the main ones. That makes sense. I hope I answered the question.
Yeah, you did. And Lauren, when you're having that outpatient rehab, do you feel that it's better if the patient comes with someone to help, or is better for the patient to come alone? I understand the issues with transportation and everything. Yes, you might need somebody, but while they're doing the therapy, it's good to have a family member there with you, or is it okay to be alone?
It's okay to be alone. It's okay to be alone if you can get yourself to therapy. It's totally okay to be alone. If someone's dropping you off, it's 100% being okay being alone. If your outpatient therapist were to have concerns and want a family member there with you, they would certainly ask. They can certainly ask, hey, I would like to, can you bring your son or bring your spouse next time? I'd like to work with them and how they can best help you with this. Then they can specify that. But by and large, it's totally fine to come by yourself to outpatient appointments.
And what's the longest a person can be in rehab? And I understand there are different levels, so I guess it depends on the level too.
It depends on the level, really. So in us, it's really there really is no set long, what's the longest. People typically really, even our most patients that have really severe deficits, if you think of somebody that's really had a heavy duty stroke or a spinal cord injury, they're typically really only staying at a max of around 4 weeks, sometimes a little bit longer, sometimes a little bit shorter, but that's really the max. That's for someone that's really, really severely disabled. Outpatient, of course, it could be a few months. Outpatient is also something that if you wanted to private pay for longer, so that's a whole different thing. And home care, I think home care, you can make a key, eventually you could start private paying for it. So there really is, if you're looking, I'm not sure exactly how long insurance would pay, but you can really keep it up as long as you really needed to, of course, if you're willing to private pay for it.
Now, if you're ambulatory, I think there are some exercises that you can do at home to help yourself at home, right?
Of course there are. And for all of these different levels of therapy, so when you're discharged from inpatient acute rehab, you're going to be discharged with a home exercise plan. When you're discharged from physical therapy outpatient, you're going to get a home exercise plan. You're going to get home exercise plans really whenever you're discharged from a therapy. Any kind of therapy, whether it be OT, PT, or speech, you'll have a discharge. You'll have a home exercise plan.
And I think that it's important that people know that you must follow that up, because otherwise you might end up, back in rehab. Sometimes we are quick to say, oh, I was there and I was doing therapy and it didn't work for me. But, at the same time, it's like maybe we weren't doing our part as well as we should have.
Yeah, absolutely. Really rehab is, if you find yourself in needing, especially acute rehab or any kind of type rehab, it's really a time where you have to do what people are telling you to do. I know we all kind of go to a medical appointment or go to some of these appointments, oh, I don't want to do that. I don't have to do that. But really, it really benefits only you to really do what everybody is trying to help you and try to have you do. It really helps you in the long run for sure.
Yeah. And Lauren, here is another question. The 3 hours of acute therapy, are they consecutive 3 hours or they're broken down? Because if it's 3 hours consecutively, wouldn't it be very strenuous?
Yes, it would be strenuous and nobody would ever want to come. So no, of course not. We work with you. I know 3 hours of therapy a day, and I should have specified, because 3 hours of therapy a day sounds like boot camp, and it's not like that. Typically, it can be like an hour in the morning, and then you could have a little break, and then have another hour, and then have lunch, and have another hour in the afternoon. So it's really broken up throughout the day. It could be that you have 2 hours of therapy in the morning and 1 in the afternoon. It's broken up. We really do our best to try to break it up and have it be whatever works best for you.
Yeah.
But typically, no, it would never be 3 straight hours. And remember that in those sessions, you also get rest breaks, right? So we're not going to make you go for an hour. You'll walk, you'll take a break, you'll walk again, you'll take a break. You'll do other exercises, you'll take a break. So it's really that you're not refusing during therapy, or you're standing up and your vital signs are dropping. There's different things that make it that you can't tolerate. But the 3 hours really means that you're doing it, but you can do it with rest breaks and all kinds of different things. So
okay. And you just answered my last question, actually, was if you could combine the different therapies during the 3 hours or maybe in between.
Yeah, so those 3 hours will always be 1 hour of PT, 1 hour of occupational therapy. You need to have, right, like we discussed, you need to have the need for both of those therapies. The third hour could be either you need speech, so that it would be PT, OT, speech. If you're not someone that needs speech, then the third hour would be whatever you need the most. Sometimes when you first come in, you need help. You really want to be able, the first thing everybody wants to do, of course, is just as an example, you want to be able to go to the bathroom by yourself, right? So in that beginning part, then OT is more needed to have that second hour than physical therapy. But then again, once you do that, then physical therapy is needed because, hey, I have 20 stairs I need to do at home. So then physical therapy might turn into be the one that's more needed. So then you'll have 2 hours of PT and 1 hour of OT instead of at the beginning where you might have had 2 hours of OT and 1 of PT. Mm-hmm. So it's really broken up that way. Mm-hmm. And those 3 hours are mostly individual. Occasionally it can be that you're being seen in a group setting, but it's mostly individual therapy for those 3 hours.
And Lauren, probably the last question of today's session. Does Burke offer multilingual services? Do you have a staff that speak different languages to cover the different ethnicities here in Rockland?
Yeah, so we have different staff. We have a list of our staff that all speak different languages. We also use a translation service called, I think it's called Proprio. Mm-hmm. And it's a video translation service. So it's an iPad on wheels. And we do a video conference with a person through the therapy session, and we're able to bring this translator around with us, which has been actually really amazing for therapy and really amazing during the sessions because it's really instant and it's perfect. It's great translation. So we're really able to get our point across. And I have seen patients, when you're bilingual, we can keep that in the room with you. That way, when doctors or nurses or anybody comes into the room, they can sign on to the Proprio and are able to communicate with you that way. If someone, isn't available, if a person's not available. But mostly we've been using Proprio.
Okay.
And we can use that for, different languages, and we can also use that if you're hearing impaired.
Oh, very nice. Okay.
Yeah.
Thank you, Lauren. I
Thank
don't
you so much.
see any other questions here, so I think we are okay to close for today. But let me first tell you what the next community chat is. So next week, we're going to be having 8 tips for a healthy heart. So February is Valentine's month. It's also Heart Month, Love Month. So it's time to care for our health and our heart health. So please join us next week for 8 tips for a healthy heart. Dr. Brian from Highland Medical is going to be here talking to us about how to get our hearts stronger. And that will be it for today, I think. Thank you so much for joining us, Lauren. Great presentation. Thank you. Very comprehensive. Very nice. And I hope, for those who are listening today, if you know anyone who needs more information about rehab, please tell them to join this session. It's going to live in the community chats Montefiore Nyack in YouTube. You can revisit this session or tell others to watch it. Please let us spread the word. Thank you so much to all of you again, and I will see you next week.
Thank you.